Welcome back to the final session of today, Session 4. My name is Lisa Kennedy Sheldon. I'm a member of the National Cancer Policy Forum, and I am delighted to be able to moderate this session. This session is entitled The Current and Future Strategies for Health Communication and Oncology. In this session, we'll discuss research strategies to address health disparities arising from issues in health literacy and communication. We are fortunate to have 4 leaders here with us to speak today to discuss emerging trends in health communication and literacy, to talk about projects and innovative methods to address these issues, and including genetics, visual design, and the role of health insurance and financial toxicity. So I am delighted to present our first speaker, April O. Dr. O is a program director in the Health Communication and Informatics Research Branch at the National Cancer Institute. She has a portfolio of research grants in multi-level health communication interventions in cancer prevention and control, including physical activity, eating behaviors, HPV vaccination, communication, oh my goodness, you have many, neighborhood and policy effects, and community health promotion. It is my pleasure to welcome Dr. O.
Hi, everyone, and thank you so much for inviting me to join all of you today. It's an honor to be here, and I'm really excited to share the NCI's priorities around health literacy and health communication. So my role here today on the panel is to give some perspective on the National Cancer Institute, which is one of 27 institutes and centers at the NIH, some of our research priorities, what we've been seeing in our research portfolio, and future directions in areas of science. So it's really from the perspective of thinking about funding future directions in research. As you see here on the slide, health literacy is one of our major priorities, and we can't talk about health literacy as a priority for NCI without thinking about health disparities. So, of course, on our website, we do have our own definition of health literacy, which is very consistent with what you've seen before earlier this morning around the Healthy People 2020 definition. But what we prioritize include the testing and effect of tailored and targeted communication, understanding the digital divide and its impact on health disparities, developing strategies for communicating uncertain and complex cancer information to diverse and limited health literacy populations, and taking different methodological approaches to really address and develop interventions for those populations. Again, as I mentioned previously, I would be really remiss if I didn't marry sort of our work and our priorities in health literacy around health disparities. And health disparities are really the differences that we observe between different social groups on cancer prevention and control outcomes. But the causes of health disparities, as many of you know, is really in taking sort of more of a social justice perspective on this, is really in looking at health equity. So we talked a lot about health equity in the other panel, but just to sort of stress sort of our approach to this is really looking at health equity as a means that everyone has a fair and just opportunity to be as healthy as possible. And this requires removing obstacles to health such as poverty, discrimination, and other consequences. And really those root causes of those health inequalities are social determinants of health. What I see and what we see as the opportunity for this roundtable is to marry our interest in health inequalities and advancing equity by addressing these social determinants of health, and health literacy is one component among those. It's a cross-cutting issue, so we fund research questions related to health literacy, health equity, and health communication across the cancer control continuum, from etiology all the way to survivorship. So now I'd like to share a bit about our NCI portfolio in health literacy and future directions that we'd like to suggest for the field. So again, health literacy we have defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services. But as we've learned today, it's even beyond that, and especially as we think about social determinants of health. So previously, what NCI has done in the past is we had a funding announcement that solicited grant applications around health literacy. And this was a funding announcement that was signed on by several other institutes at NIH. It was first issued in 2004 and reissued several times before it expired in 2016. After that, it was not reissued. Rather, health literacy has been integrated in many other funding announcements across NCI, as well as across the National Institutes of Health. So what I'd like to share is a portfolio analysis that was conducted between 2010 and 2013. So these were grants that were submitted to NIH more broadly. And what I'll do is focus specifically on those projects that were submitted to the National Cancer Institute. I would like to share with everyone that among all of the different applications that were sent to the NIH during this time period, the majority of them did get assigned to the National Cancer Institute. The National Cancer Institute and the Health Communication Informatics Research Branch is actually one of the only branches within the National Institutes of Health that focuses on communication science. So we found a couple of trends in this analysis. First is health literacy. When we looked at health literacy as the primary research aim, so typically in a research grant, you submit at least 3 to 4 research aims as part of that grant application. And when we coded those research aims, we found that most of the portfolio really focused on intervention studies, development of an intervention, and testing and evaluation of an intervention to address health literacy. Most of them targeted specific racial ethnic populations as a means to address health disparities. Some examples of those include development of a tobacco health literacy measure for American Indian populations. Another intervention was a library-based nutrition literacy program for rural older adults. When we looked at those interventions and some of those projects, what we did is then coded those interventions across the cancer prevention and control continuum. And as you can see here, most of those projects really focused on cancer screening, and then followed by informed shared decision making, and then followed by patient-provider communication. And you'll see that across the cancer control continuum, there's also other areas where these interventions have occurred or were taking place. What we'd like to highlight is, as we're looking towards the future in sort of cancer prevention and control, is that there are many other opportunities to think about those lessons learned from those interventions, whether it was a tool developed, a website that was developed, a mobile health application that was developed, a sort of decision-making rule or process that was developed in these interventions, thinking about how you can take those lessons learned or how you can take and build upon that science into other areas within health literacy. For example, precision medicine, genomics, clinical trials, digital health. So I want to highlight here that point. This is the REAIM model, which is a dissemination, really a program evaluation model from Russ Glasgow and colleagues. Health literacy has a real opportunity here as we're thinking about taking the interventions that we have developed, many that were shared already in this room, and thinking about bringing them up to scale. How can we take those interventions, those tools that were already developed, and to reduce disparities and enhance reach, bring them to other communities? Can we think about how do we reach those targeted populations? How do we know that the intervention remains effective when you look at different contexts? How are interventions adopted to include health literacy levels of specific populations? Are you sure that the intervention has been delivered properly? And how can you incorporate the intervention so it's delivered over the long term? I heard that some folks talking about user-centered design. Health literacy is not going to be a static issue, right? So as the population gets the health literacy intervention, their behavior is going to ideally change, and their literacy levels will also likely change. So how can we adapt our organizations to meet those needs as the population changes? Related to that is really, as we're delivering these interventions, we want to make sure that we're not exacerbating health disparities, that we are really looking carefully at how we're delivering the populations, who is actually getting those interventions, and their reach and impact. The other trend that we found was that most of the interventions were really focused on one level. If we think about an ecological model of all the different influences on health behaviors and outcomes, many of the interventions really focused on one level, and primarily the patient-provider level, 77% of those interventions. But if we really want to advance population health and advance health equity, we understand that it's not just one level of influence. Context matters. And so incorporating more than one level of influence in impacting cancer prevention and control behaviors and outcomes is essential. This is one model that came from Steve Taplin and colleagues. It's really just about the healthcare context, healthcare delivery context, but you can imagine that as we include the public health context as well, there's certainly multiple levels of influence. Rima Rudd recently published a paper that did this really nice comprehensive assessment of the history of health literacy and future directions for aging. But I thought this quote was especially salient. Overall, the physical, social, and normative environment of healthcare settings can inhibit or facilitate the application of existing literacy and health literacy skills, as well as the practice of efficacious communication efforts. So context matters. The third trend that we found was around the intersection between technology and health literacy. So as we looked at the portfolio over time, we found that from between 2010 and to 2013, the amount of integration of technology increased from 58% to 78%. And there's so many different ways in which digital technology has been incorporated. One of the things that I'd like to really encourage folks in the roundtable to think about is that intersection, that while we have this great penetration of technology and this great potential for enhancing reach, there still is the potential for communication inequalities. So communication inequalities, as defined here by Vish Vishwanath, is communication inequality refers to differences in the generation, manipulation, and distribution of information across social groups, as well as differences in access to use of information channels, attention to media content, recall, knowledge, comprehension, and capacity to act on relevant information among individuals. So one of the things that many of us got really excited about, including policymakers, researchers, and interventionists, is that the digital divide is now closed. We all have access to the World Wide Web, and we all have access to mobile phones. Well, there's actually what has been posited in recent publications that I have here is there's actually two levels of this digital divide. One is just the access to the technology and the access to the broadband so that you can actually get the information when you need it and when you want it. The second level of that is actually how you use that information. Is there a fee to access that information? Are you able to understand the information that you get from your portal? Is there a cost to download that application? Do you understand the software and hardware issues? And so it's not just the reach of that technology. There's other levels that we have to think about when thinking about technology and health equity. So I want to share some future directions to reduce communication inequalities. So as I mentioned before, one is including examination of that intersection between health literacy and digital health. That there's two levels to think about. That it's not just the access to the technology itself or the broadband. That there's other areas within digital health that we really need to understand and how that intersects with health literacy to benefit our populations. The second, as I mentioned a couple of times, context. Context matters. Thinking about the different ways, whether it's the individual, their family, the provider, the health system itself, and also the community. We've really focused a lot about the health care context, but most of the time, our patients live outside of health system walls. And so as a consequence, that has a huge impact on how we process information, how we get information, and how we respond to information to ultimately change behavior. So to really impact that health equity question, we really have to take into account those different contexts. The other piece is inclusion of participatory methods in defining health literacy. I've offered one to health literacy definition, but patients themselves may have a different definition for health literacy, as may providers or community organizations. So it's really important, I think, in taking an engaged approach to identify what that definition is, what's the values and goals for health literacy, and where do people want to be with their health. The other piece that I mentioned was around dissemination and implementation research. So again, to make sure that we're not exacerbating health disparities, really thinking about how we can take what we already know. And the health literacy field is not young. There's a lot of great interventions, and we've identified many of them, and there's still others that are developing. How can we take those to scale to really benefit people now where they are? And as we're doing that, are we taking the iterative approaches to understand that behavior will change? And if you have an efficacious intervention, the health literacy levels will change. And so how are we adopting and adapting to that change? The final is that, again, settings and contexts where research is occurring, recognizing that there's some different environments, communities, contexts where the health literacy interventions are really not reaching. And in order to reach those populations and understanding those contexts, a focus on that would be needed. So I want to share here, because I mentioned earlier that one of the health literacy funding announcements has closed, but the approach that we took at NCI was to integrate that health literacy priority across multiple funding announcements. And I also mentioned that most of the NIH and NCI grants that are funded don't necessarily come directly to a funding announcement. They're unsolicited. NIH is about discovery and science, and you can submit any sort of research idea you'd like to with your research team, and it does not necessarily have to go to a specific funding announcement. But I do highlight these here because these announcements do have opportunities that touch on multi-level components, dissemination and implementation science with health literacy, and health literacy broadly. So I'd like to thank you for your attention and also acknowledge my colleagues at NCI, Sylvia Cho, who you heard from earlier, Maureen Clark, and Anna Gajzenski. And I encourage you to all follow us on Twitter. That is where we provide more information on funding announcements, tools, trainings, and opportunities. Thanks very much.